My name is Jessica Wetzel, and I am the e-commerce manager here at Schoolhouse. And I want to start off by thanking you for joining us today and participating in our webinar with Barbara Smith, owner of SchoolMeds.com, and Phil Johnson, a registered pharmacist and author of Medication Use in Schools, a nationally distributed resource that actually won him an award from the Institute of Safe Medication Practice. The topic, as you know, for today's webinar is how we can address some of the challenges related to medication safety practices in schools. And in my conversations with Barbara, I have witnessed firsthand her passion for this topic and her desire to provide relevant and meaningful education to you. So I'm excited to be able to bring this webinar to you today. And I also wanted to make mention of the fact that due to the huge response we have received for today's webinar, with almost 1,000 people registered, we are working on scheduling additional webinars around this topic based off the questions we received from you today. But before I turn the time over to Barbara and Phil, I would like to review a few quick things about today's webinar. First, we will not be taking audio questions, but would like you to submit your questions via the questions interface in GoToWebinar. Second, Barbara and Phil are planning to take 40 minutes for their presentation, after which we will take the questions as they arrive. You can type in your question anytime during the webinar, that's fine. And, but just know that after the presentation is when we'll have the question and answer session. Third, this webinar will be recorded, and a link to it will be posted on the schoolhouse.com website, as well as emailed to you for future playback. So you will receive an email after the webinar that will have a link to this recording that you can listen to. And lastly, everybody who attends today's webinar will receive one free access to SchoolMed's online course, as well as a digital copy of Phil's book, Medication Use in Schools. And at the very end, we will be picking a winner to win a medication skills observation kit. So quite a few fun things planned today, in addition to all of the education. And but without further ado, I'm going to turn the time over to Barbara and Phil, and I believe Barbara's speaking first. So Barbara.
Okay, thanks Jessica, and thanks to Schoolhouse for putting on this webinar, and to all of you for your interest in this topic. I think most of you are school nurses, so I'll be addressing you directly, but I know that there are also administrators in the registrations and others who are critical to making school health programs work. I've been working with school nurses on public awareness and training issues for what is now decades, and continue to be amazed by what you do. I was introduced to you as a group when I worked at the University of Iowa through Charlotte Burt, Iowa's state school nurse consultant at the time. We worked on a number of education projects to demonstrate the work that school nurses are doing to include children with special health care needs in the schools, and then also to develop the online medication management training for Iowa. If you are a nurse, you know a lot about medication safety. What I would like to offer as someone who has been observing and documenting your work for a while is some of the big picture themes that I see that affect medication safety in your everyday environment. And then Phil will talk about some of the things going on in other settings, other healthcare settings that could be part of helping you with safety improvements. In an interview I did many years ago, a school nurse in Waterloo, Iowa told me, "We deal with everything from broken hearts to broken bones." Medication administration is, I know, a big part of what falls in between there. As you can see, this part of your work has become more complicated and time-consuming in recent years. But since those big picture items are so much about concerns and challenges, I do think it's important to keep in mind the important and positive historical change that you are part of. That because both of changes in education laws and our growing understanding of the relationship between health and learning, medication administration is sometimes what is keeping kids in school with a chance to learn. The first big picture item that I know you are all familiar with because it is simply that you are the, and I say the because it is often just you, healthcare professional in an education system. So even though you are it, your ability to implement safety procedures can be limited. Julia Lear, the director of the Center for Health and Healthcare in Schools, writes about school health as a hidden system of care. This influences all your work, but the hidden part is certainly strange since more medications may be administered on a daily basis in schools than in major hospitals. And a recent NASN survey reports 13% of students receive medication for 90 days or even more during the school year. A second big picture item is that there are not enough of you. This affects everything you do, but medication administration is certainly a big part of it. I know this has been a long effort for you, and the efforts are paying off, however slowly. NASN reports that 38 states have increased school nurse physicians in the last decade. And despite the terrible funding situation in schools, the powerful tool of setting standards, like one nurse for every 750 well children, is something many of you have grabbed onto and are using in your advocacy. It helps a great deal to be able to say where you want to be. A third issue related to the second issue is delegation. Most of you must delegate some of your medication administration responsibilities to unlicensed assistive personnel, or UAPs. A UAP would be any staff who is not a licensed health professional, and this would include the school principal, a coach, a classroom aide, a teacher, a secretary. The issue of what you can and cannot delegate by law and what you are comfortable delegating to whom is extremely hard to sort out between your nurse practice laws, district and school policies, and the need that is in front of you every day. Anne-Marie McCarthy and her colleagues at the University of Iowa conducted a survey of school nurses who reported errors were 3 times more likely when UAPs administer medications. So these 3 big picture items that affect your medication safety efforts: location, numbers, and delegation. Improving medication safety is going to take a combination of collaborative advocacy and things that you may actually have some immediate control over on a day-to-day basis. Some things to think about. The facts are always friendly. Sometimes it doesn't seem like they are, but they are, because they give you something that you can use for change. It has been difficult for researchers sometimes to gather facts because of the range of systems you work under, and because, as Phil will elaborate on, you don't have the mandatory reporting systems that other healthcare systems have that result in data. But I'll give you a couple of examples of what can be done even without those broad mandates. Daryl Canham and her team in San Jose performed a medication audit at 10 schools. They developed an audit form and reviewed every medication given during a year in those schools. This was obviously a lot of work, but it gave them those friendly facts that they could use immediately to implement training and procedural changes for safety. A partnership with a College of Nursing researcher like Canham would obviously be helpful for an effort like that. But it is possible for this to be done on a smaller scale too. I've picked up a story of a Wisconsin school nurse who analyzed medication issues and was able to come up with a documentation of errors, which she took to her school board to tell them about an unacceptable situation and to advocate for more nursing help. But a really powerful starting point for this is to make sure everyone knows what a medication error is. Failure to follow the 5 rights, or what is referred to as the 6th right documentation, has a lot to do with errors. Everything that has been done to look at medication errors at school show that missed doses account for the largest number of errors by far, and I mean 60, 70, 80%. Even some nurses in the school label missed medications as a no-show rather than an error. While we tend to hear about the dramatic violations of the 5 rights in someone giving the wrong medication or a dosing error, this large indicator that medications are not being given as prescribed has to be contributing to poor disease management, antibiotic resistance, and other problems. Sandra Richmond, a school nurse in Pennsylvania, wrote an article for NASN School Nurse outlining some things in the school setting that can help with medication errors. One is training. Obviously, I'm a believer in training and education as a tool for positive change and competency development as well as for documentation. But training is also sometimes used as a quick solution to throw at a problem. It is not easy to measure the effects of training on performance in the school setting, partly because it's so interlaced with other variables. Training, yes, but training for yourselves and for school staff that focuses on what people need to know and be able to do, not as the medication safety plan or to show that you've done something about a crisis. Following guidelines is another safety measure that Richmond mentions. They are there for you to use, both to implement and for advocacy. NASN, the Academy of Pediatrics, and others have position statements, policies, and guidelines that many of you have used in developing district policies. You don't have to invent these. Time is another thing she mentioned. Undistracted time set aside for this important task. This is needed for the nightmare image we have of the secretary answering the phone, selling lunch tickets, and administering medications at the same time. But nurses, in fact anyone giving medication, needs to be able to focus on that task to do it correctly. I would like to add a final and perhaps the most important effort in identifying and addressing barriers to medication safety. I was talking to a friend the other day who was a nurse practitioner midwife for many years and now works for a visiting nurse association. I was talking about some issues in school nursing, and she said that she had served as a school nurse substitute for a brief period, and she said, it made me feel very alone. So yes, I think that is related to your location challenges, because they can make for feeling alone, not having other people right there with your health priorities or to consult with. But for your advocacy efforts and your implementation of improvements, you need to make yourself known, not as a hidden system, but be recognized by organizations in your state and community working on children's health issues. Phil is going to talk more about the need to join in these other systems and some ways that you might do it. There are lots of partnerships available for you to cultivate that would be helpful. But here are a couple of quick ideas. One of the keys to medication safety that Richmond also proposed was about creating a non-punitive error reporting system. The Institute for Safe Medication Practices has been doing this for other healthcare settings for 30 years. Phil will be talking about them in more detail, but they are already receiving some reports from the school setting, and they are already definitely your friends. They are located in suburban Philly and have been in the press and vocal about the cutbacks in school nurses there. And many of you already have relations with good relationships with local pharmacists, but you might think about a more sort of systematic approach as well. I noticed that the Cleveland Clinic has a special pharmacy helpline. It's called RxPert, I think, to support school nurses and other school staff on medication safety issues in Northeast Ohio. Other health systems might be willing to replicate something like that in your area. And don't forget parents. Remember the people who are most affected by medication safety, other than the students themselves, are the parents. In your day-to-day life, sometimes you may not see that. Parents are also the ones who forget to bring refills or can't find paperwork or send medications in baggies or ask you to bend the rules. But it was parents who 50 years ago brought children with disabilities out of institutions and created, and by the way, also got funded, the education laws and system of care that we take for granted now. Parent organizations and individual parents have the stories and the influence you need for your advocacy for a safe school environment, and they definitely should be cultivated. So, as a summary, the big picture items that I think are affecting your day-to-day safety practices are location, that you are in an educational system, your numbers, which are not enough, and the complicated issue of delegation. I also talked a little about the importance of gathering facts to guide change and advocacy and developing partners in and out of the healthcare community. And of course, your own stories are always important. On National Public Radio's Weekend Edition last Saturday, Philadelphia's school nurse Eileen DeFranco was interviewed about the crisis there in school school nurse firings. She said, "I think of educators as a caring web that surrounds our children, and there are gaping holes in that web." So I'm happy to turn things over to Phil Johnson. He is one of your partners as a healthcare provider, but he also brings along that parent perspective, and he's part of that caring web.
Okay, well, first of all, thank you. I really appreciate the opportunity to address these things with you. And Barb does have some more issues to talk about when we finally get those things fixed related to training. But what I'd like to do is I do a lot of work. I'm a pharmacist. I do a lot of work with medication safety and healthcare systems. And the first thing I'd like to do is kind of relate the national healthcare crisis and Affordable Care Act that we're undergoing now, and relate that to the school health situation. Currently, as you probably heard too much of on television, the healthcare costs have increased from 11 to 17% of the gross national product over the last few years, and that's an unsustainable cost resulting from higher drug costs, operational inefficiencies, and just poor disease management. These costs are unsustainable. The disease management failure results from poor patient compliance to a healthy lifestyle and to poor therapy adherence. I was just actually this morning at a conference in Orlando that was primarily healthcare payers, commercial insurance and Medicare, and 75% of the payers listed patient noncompliance as their top priority and the top reason for medication therapy therapy failure. Schools actually can have a huge impact on both improving the lifestyle of the student and teaching therapy adherence during the 12 years that they're under your care, or 12 or more years that they're under your care. Access to care is also a national concern, and it doesn't. Most people aren't aware of the fact that schools provide therapy to 6% of our nation's children every day. So you are a huge player in providing access to care. Quality of care and safety have also become a major concern, and school safety issues are currently making some of the national headlines, not in a positive way. Also on the national forefront is the need for integrated, transparent care, linking all of the essential partners. Care is getting more complex these days, and some of the therapy is becoming very difficult to manage. It's important that all the caregivers are integrated and coordinate with a student package, and so they see the same, share the same student or patient record, and contribute from their own perspective. So schools are certainly an essential part of the integrated care, and should be included as one of the national providers. The other thing that's important to understand is the National Notice of Medication Errors. There was a landmark study from the Institute of Medicine in 1984 that showed there were 98,000 preventable deaths per year from medical errors in hospitals. In 2013, that study was updated and looked at again. It's estimated that there are now 400,000 preventable premature deaths resulting from preventable harm each year in hospitals. And you can extrapolate that if that's happening in hospitals that have fairly tightly controlled systems, there's also preventable errors in other healthcare systems as well, such as nursing homes and schools and any place where medications are administered. The majority of the errors in both of these studies were medication, and all healthcare facilities must acknowledge their own vulnerability. One of the quotes in this second study was from Sophocles: "All men make mistakes, but a good man yields when he knows his course is wrong and repairs the evil. The only crime is pride." In addition to this, we need to ask, why is this happening? And the main reason is because the healthcare systems right now are more fragmented than ever, and providers don't have a complete picture of the patient. They don't get the latest changes in dosing, for example. They don't always get notice when the therapy should be discontinued or when a new therapy should be added. So we find students getting duplicative therapy and doses that are not appropriate for their disease. So all of these contribute to the national error problems that we have. What's in the news today? Well, as some of you probably know, errors that have contributed to harm of students or even student death are in the news. And these are some of the headlines from Philadelphia, Milwaukee, and Los Angeles. The denursifying of schools puts children at risk, added risk of medication errors. Then there's outrage grows over 6th graders' death due to the asthma, or basically access to the inhaler that would be needed to control that student's problems. And actually, that's how I got started in my interest in healthcare. As my son had asthma, and it became an annual event to try to make sure that he had access to his inhaler, and that everyone knew how he should be using it. And so anyway, that started my long 30-year history of working with school health on various issues. So anyway, these are all things that are in the news. There's obviously a lot more in the news about medication errors in larger healthcare systems, but schools are also in the news. So what are the problem areas in schools? Let's look at these based on several studies. The types of medication errors, the number one error is missed doses or noncompliance. And when I surveyed schools back about 10 years ago, many schools did not consider a missed dose as an error, but it truly is. You can also find that some hospitals don't consider that as an error, a reportable error either, but it truly is. A wrong dose, of course, is an error. Well, a missed dose is really a wrong dose because it's 0 milligrams. It's no dose at all. The wrong time is an error, and then there's controversy over how far off from the scheduled time do you have to be before it's wrong time. And I think most people would consider if it's a daily dose, as long as it's given in the right half of the day, you're probably okay. And if it's a scheduled TID or QID dose, probably within an hour of the scheduled dose, is probably okay. Certainly, if the wrong patient is not acceptable, the wrong route is not acceptable. And the biggest error with wrong routes is actually between eardrops and eye drops, and sometimes also injectables that should be given subcutaneously or given IM, and that can sometimes cause huge problems as well. Then, of course, drug diversion is always a problem. It's not really a medication error, but it is a medication problem that plagues every healthcare delivery system in the country, including schools. Medication order accuracy is a particular problem with schools because you sometimes relying on another party, the parent, to relay information that a dose has been changed. And sometimes the schools, in the study I looked at, was involved with, sometimes for some of the seizure medications, the doses were 2 or 3 changes old, either too high or too low. And that's a problem with some of the policies that relate to the ability for the school and physicians to interact, or just opening networks of communications. Documentation on the medication administration record, or the student medication administration record, the SMAR, whatever you call it, it's called different things regionally, is very important, and it's not always accurate. You're not alone, because in hospitals, some studies show as much as 25% of medication are not administered. That's an extreme study, but almost every hospital will show that when you get in a hurry, or it's some of the PRN medication that's maybe a Tylenol or something that isn't considered too significant, sometimes they're forgotten to be documented. So this becomes a huge problem. And it's also a problem in tracking medication where the student is self-administering. There's some ideas I have under the technology section, perhaps using mobile phones and some medication-related apps that would help with student self-documentation, maintaining a medication diary for those students who are self-administering. Then just the whole issue of when you have errors and adverse drug reactions, how are they reported? Then you have the issues of stock and emergency medication, specifically storage errors or issues that could lead to drug deterioration. I think most schools now are aware of the fact that the rooms have to have certain climatic conditions. They have to be kept within certain temperature ranges, or refrigerators have to have thermometers in them. But that's not always the case, and if the drug deteriorates, then of course the student's not getting the full dose that they should. They're usually getting a much lower dose than normal. The factors contributing to medication errors in schools, the main one is that the drug's not available. You've run out, you've asked the parent to send more, and it just isn't there. The accuracy of information, the current dose or the allergy status that may have changed is not always relayed to the school in a proper manner. It could be an inconvenient schedule for the student, and the student's not available. And so this could be an error as well. And if that's the situation, it's entirely possible to work with the parent or with the physician to maybe come up with a different schedule for the medication that is acceptable and that fits into the student's schedule. There's also very restrictive, inconsistent school policies. Lack of resources, Barb talked a little bit about that. Then there's student peer pressure to don't take your medication, or in some cases to share their medication. I have personal history with that, where my son started asking me, going through his inhalers. He used to use about one a month, and then all of a sudden it was every 2 weeks. And I said, "What's wrong?" I said, "Is it worse?" He said, "No, during PE class the kids are asking me to share it so they can run faster." Well, that was we put an end to that very quickly. But there's all sorts of student peer pressure to either take or share or use or not use the medication. Other factors are just pure misinformation or inadequate training of staff or the student, especially if the student's self-administering, and improper storage and drug diversion. Some of this we also looked in the 2003 survey we took, and this was fairly consistent with the University of Iowa's survey that was done about a year ahead of mine. What policies do the schools have? And most schools are pretty good about having a general prescription medication use policy and medication storage policy, pretty good about non-prescription OTC policies, and I think that's getting better because it's been in the it's been an active issue for some time now. But there's probably still some room for improvement on policies related to discontinuation of meds. How are they disposed of or returned to the parent? PRN use and medication waste and disposal. Off-campus use is also something that's important, and as is self-administration and nurse-initiated emergency medication. These are all hot issues currently in some parts of the country, and policies need to be established to help standardize these situations. There's also some legal issues for the schools. Under hospital and nursing homes and licensed healthcare facilities, we have HIPAA, which is the Health Insurance Portability and Accountability Act. Basically, it's intended to protect personal information of the patient. Schools have FERPA, which is intended to do the same thing. They both have the same goal, and that's to protect individual information. Unfortunately, sometimes the hospital says, well, the school doesn't meet HIPAA regulations, and the school says the hospital or the healthcare, the physician's office doesn't meet FERPA regulations, and so they don't share information. There needs to be some policy established for one to accept the other. They need to be mutually accepting to facilitate two-way information exchange. I hope that isn't a problem in too many schools, but I know for a fact it is in a couple schools. So in school, the other issue I think from a legal perspective is school health really must be recognized as a healthcare facility for a couple of reasons. Recently it's come up, more schools are adopting EpiPen use. They have to be able to purchase it. In Florida, for example, there's a statute passed allowing schools to purchase EpiPens. Well, they have to be a licensed healthcare facility to actually purchase that product from a drug distributor. And so, or somehow the state has to recognize the fact that some kind of a school certification number is acceptable in this process. So that legal issue has to be addressed. And then school health must also be recognized, and accountable to basic practice requirements. In some states, or some school districts in some states, I've been told that the nurse is actually not under the Board of Nursing or any other healthcare facility. They're actually operating as an agent of the parent. I hope that that isn't widespread anymore, but 10 years ago when I looked at this, it was actually prevalent in some of the counties throughout our country. And so that's an issue. It's something that I think most nurses, whether working in that situation, assume that they were nurses and are going to follow good nursing practice anyway. But from a legal standpoint, the school should adopt the basic practice standards of nursing, and also pharmacy from the perspective of the storage and management and labeling and documentation of drugs. So from a legal standpoint, individual state laws are inconsistent, and so is the provider status for school nurses. Malpractice liability and liability limits is also inconsistent from states, and there's also a state-by-state concern over drug diversion. So all of these are issues legal issues that should be addressed. I don't have answers for these, but they're issues that certainly we can work on together. When there is a medication error, most of the healthcare systems, hospitals and nursing homes report through the MERP system, the National Medication Error Reporting Program. The information is confidential. The Institute for Safe Medicine Practice is who manages this. They're a federally certified patient safety organization, and I work very closely with them. Actually, they're very strong proponents of good school health. They report these medication errors, and they also report close calls or near misses. What they would consider as errors that are reportable are errors in prescribing, transcribing, dispensing, administering, and monitoring of medications and vaccines. Schools are probably going to be mostly in the area of administering the drugs, and I would encourage you, and they are willing to accept school health error reports. In fact, they have received a couple already, and are very excited when this happens, because they really want to help the school health situation. So what should be reported is the wrong drug, wrong strength, wrong dose errors, wrong patient errors, certainly wrong route of administration, calculation or preparation errors, and the misuse of medical equipment. And that primarily would be like an insulin pump or something, some kind of an IV administration device for the most part. So the question comes up, how did hospitals drive change? And I can tell you that 20 years ago, medication errors were a huge problem. It started with that Institute of Medicine report that showed that 98,000 preventable deaths occurred in hospitals. Got a lot of attention, and it created, that's what started basically ISMP as an organization to start focusing on medication safety. Started with educational programs, and the first thing they did is introduce the concept of a culture of safety, because medication errors and reporting of those errors and trying to do something about it really is a cultural issue. If it's a punitive environment, people aren't going to report errors. So they basically started talking about what should be a fair and just culture, a non-punitive but accountable culture. So safe processes were then established and practice standards, and they have standards for how drugs should be labeled, and how they should be ordered, and how they should be documented, and all of that, everything related to medication errors. The other thing that they're very strong about reporting, in fact, when you report errors, they will sometimes give feedback and ask and go through a root cause analysis. And so what is the root cause? What caused that error to happen? What within your system can be corrected to prevent it from happening in the future? So they have educational tools to help you work through a root cause analysis, and also they have self-assessment surveys and databases, and this is where I've worked with them. I actually led an international task force to develop safe medication standards for oncology drugs. We had 23 nations involved with that. It's a long checklist of everything you should do to make sure that there are not medication errors and that everything is safe in the process of oncology drugs. They have the same thing for nursing homes, the same thing for regular hospital care, and they're willing to develop a similar survey, self-assessment survey for the environment of school health that would basically look at the processes that should be in place, where should you have your checks and double checks, what should be documented, and how do you assess when there are errors and make corrections so they don't happen again. The other thing that happened in hospitals was the Joint Commission accredits hospitals, and they adopted patient safety standards again about 20 years ago with all these errors hit the national news line. And so we actually had standards that we had to meet, and so we had to make changes. The other thing that happened was the Agency for Healthcare Research and Quality developed safety standards and never events. Never events are things that should never happen in a hospital. They usually lead to permanent damage or death of a patient, and when they do happen, a large team of investigators come in and do a root cause analysis for the hospital. There's usually the accreditation of the institution is compromised, and quite often there's certain financial penalties that are also derived. So hospitals were really forced to make changes. And what really had to happen was the hospital leaders had to acknowledge and place that safety was an issue and place patient safety as an urgent priority. Medication error reporting internally had to take place, and then later medication error reporting through the Institute of Safe Medicine, that MERP program. In the process of looking at the errors and trying to prevent them, we did something called value stream mapping, where we take the work process, everything from the point in time where a drug was ordered to where it was transcribed into the medication administration record, the pharmacy dispensed it, the nurse received it, administered it. There were double checks at various stages. For example, an insulin dose. The syringe, the insulin dose would be drawn up, and 2 nurses would have to check it. This double checking happened in the pharmacy too, where a drug would be drawn up from a vial, and it would be double checked before it was added into an IV bag and a label placed on it. So we identified critical points, error-prone points that were targeted where redundant checks had to take place. In a school, you don't have that redundant checking necessarily. You can't have 2 nurses check, but there might be a second person who could make some checks, or you could have the student enlist the student to verify, that the syringe was, if it's insulin, that 10 units were drawn into the syringe, and it was the correct vial. And it's a good way to teach them also to double check themselves or have a family member double check. Eventually also, safety was included in hospitals in all providers' job descriptions. All nurses, all pharmacists, all physicians, all respiratory therapists, dietitians, radiology techs, all had patient safety and medication safety included in their job descriptions. Eventually, medication safety officers' job descriptions were established, and then ultimately software was developed to prevent and document and report errors. A good example of that, of software, would be dose range checking on drugs. So the software, the computer system would know what a standard dose would be for a child or for an adult. And if you entered 10 times that or a tenth what was expected, if it was something out of the range, an alert would go up and you'd have to override it and validate that that's actually what you wanted. So that prevented a lot of the dose errors. Some of the other things that hospitals did, to drive this change is they really, it's obviously minimizing medication errors is the right thing to do, but there's a value to it. And so they started measuring what is the return on investment and found out that by creating a safe environment, they actually, it was also a good financial investment. Part of that was because some of the insurance, some of the payers, developed the concept of pay for performance. And pay for performance was really a penalty for preventable errors. So in other words, if you had errors that ended up with extended stay of the patient or readmission to the hospital, you weren't reimbursed for that. In some cases, you were penalized for it. There was also medical liability suits that were prevented. There was also the impact of negative headlines on consumers. And there's a couple of classic stories I won't get into within healthcare. But some of the major hospitals in our country have found themselves in the headlines because of medication errors. And this got the administrator's attention, and some of these institutions are now the role models for safety. They've changed it that much. Colleges of nursing, pharmacy, and medicine began teaching the importance of safety and safe systems, and safety metrics were developed and started being published, and there's many articles now. 20 years ago, there were very few articles on safety. Now there's, every month, there's a couple articles related to safe use of medication or error prevention or an alarm over a new type of error that may have happened. But the important thing is to really establish a just culture of safety. It started out as a non-punitive. The goal was a non-punitive culture. That really didn't work very well because there's 4 types of errors. There's human error, there's negligence, then there's reckless conduct and knowing violations. And you can't, some of those, if it's a known violation and absolute reckless conduct, you have to get into some kind of a punitive mindset, some kind of a punitive action. But really, for most errors, are not intentional. Nobody wakes up in the morning and says, I'm going to go and create an error and hurt somebody. We just don't do that. And we all make mistakes. We're all humans. And so you have to have a culture that is forgiving, where you can really report errors and unsafe conditions and do something about it and improve the quality of care for patients in your institution or in your school. Part of that is establishing a clear policy and review board when things happen. And in the school, perhaps you could set up a district review and look at the safety procedures. You can also develop a review process such as a root cause analysis to see if the system is causing the problems and what can be done to fix the system. And you might find that that's related to a certain policy, and that might be throughout the whole school district that you're working in. Hospitals certainly found that when they did a root cause analysis, there were processes in place that affected every department in their hospital. And so an error made in one, the action taken would prevent errors made in other departments. The benefits of a just culture are that employees adopt an attitude of learning and sharing to create safer systems. And this also helps in the design of new systems that are more safety-minded when they're introduced. The bottom line, though, is that stress leads to errors, and if there's a fear of punishment or a fear of what's going to happen when you report an error, that's just going to add to the stress, and that's going to cause more errors. There's also the importance of safety-focused informatics, and I know there's a lot of electronic systems that are now being developed in the schools. In hospitals, in healthcare pharmacies, physicians electronically enter orders, and that really decreases the amount of errors and adds to the clarity. There's no transcription errors, for example. There's also, you can build into this ordering process some certain standards. For example, drugs that should never be given through one route, you would not be able to order it in a certain route of administration, or the dose range checking that I already talked about. I would hope that the school's medication administration records have some built-in checks and balances, so that to make sure that, first of all, that the drugs are listed, that allergies for the drugs are there, that the doses, the standard doses for are listed somehow, and serve as a guide to make sure that excessive doses or inadequate doses are not given. There's all sorts of checks and balances that can be put in place with the electronic systems. And I know these are getting more sophisticated, but my recommendation is that you work with the people who are your informatics source provider, and identify to them the concerns that you have that might be safety related, in ways that they could help you have a more automated process that perpetuates safety. So the standard medication error prevention strategy is: 1, acknowledge that errors are a problem, define and report errors, educate the staff and involve all the staff, educate students and parents on safe and effective medication practices, notify parents and primary physician of all errors and adverse reactions, develop and adopt policies for all components of medication use, train and credential staff and hold them accountable, and that's any staff that would be involved with medication storage and use, and that could be a person in charge of students on a field trip, it could be a coach, it could be anybody involved with medication, with the student and medication. Then document the positive impact of prevention efforts and document the negative impact of errors. And this will help you sell your services and get the resources you need in your institution. Share the information with other schools, and partner with colleges and health systems, and even pharmacies. A lot of community pharmacies are involved with school health services. They can provide valuable resources to you. Finding the school health resources, I'm getting a little short on time here, so I'm going to move along pretty fast. But one of the things that I really wanted to emphasize is that you really have to start proving your value, because that's what we had to do in the hospital systems. Is we had to start showing, as pharmacists, we had to start showing what the value of, for example, a clinical pharmacy was. Okay. One of the things we had to do in hospitals is prove our value and the impact that we had, positive impact we had in patient safety. And I think that's one of the things that you need to do is create a compelling story. And you need to target that story to the various stakeholders within your system. I just wanted to run through this. Typically, I think there's a tendency, at least there was a tendency in hospitals, to only address the administration of your institution when you're looking for the resources you need to expand your scope of service. But there's other people, there's other stakeholders who are really interested. School administration, of course, controls the budget. And couch your request for additional resources in what they're looking for. They're mostly interested in attendance and school performance. We both know that proper use of medication will decrease absenteeism due to illness, and also will enhance school performance. But there's also other people. Payers are very concerned about students who access emergency care through emergency rooms because their medication is not controlled. And you can find allies within the payer system, within the insurance providers that they have a lot of information on disease management that they can support. And over time, if we can do studies and show the impact of school health in maintaining the student who has a chronic disease or even an acute disease, maybe there could even be some support from payers. Society, of course, wants a healthier population and better students. And we all know that students learn better. Students who are properly, their diseases are properly managed, learn better, and so that's important to know as well. That's okay. So again, there's a lot of resources that are available. One of the things we're going to provide you with is this book that was developed about 10 years ago, but there's still a lot of good information in it, and it was developed by a committee of school nurses, and there was also about a dozen physicians in various specialties and 5 pharmacists, and so we address a whole lot of issues. My summary is that medication errors are preventable. Errors happen when resources are inadequate. Systems are stressed, policies are inadequate, and processes are inconsistent. Staff is not adequately trained and held accountable. Teaching students and reinforcing proper medication and safety during school year should result in a more health-compliant adult. School health services can add tremendous value to the national healthcare enterprise. What I'm suggesting is that, I think, the resources you need, you will only get if you can prove your value. And prove your value, you have to be able to express the impact that good health has on the student, not only while they're in school, but in the future as an adult. If you can train a student to be compliant with their medication and to monitor and manage their disease, they'll tend to do that better as an adult, and that will be one of the things will help get the resources that are needed and get the attention that we need. As far as medication errors and support in that area, unless you can show that errors happen and what the cause of those errors are, you probably won't get the added resources that you need. One of the things we did in hospitals, the pharmacy had to show the types of errors that we had. We had to admit we're making mistakes. We had to say, without adequate resources, we're going to continue to make medication errors. It's going to have a negative impact, and that's what eventually got the resources at pretty much every hospital to address patient safety. So those are my thoughts, and so I guess we need to, if we have some time left, Barb, are you able to add some more comments? Hello?
So, hi, it's Jessica.
Yeah.
Barbara and I were talking. We are drawing into a close here. We have about 5 minutes left. And what we're going to do is move on to some of these great questions that are coming in and draw the winner. And Barbara will record her part for the big dissemination of the recording afterwards. So we will send out a recording via email to everybody, and Barbara's part will be added to that recording. So.
Good.
We can do that. Here's some quick questions, though, coming in here. Carol says, my biggest issue is parents who give their kids OTC meds before school and write a note to the teacher, and the information never gets to me. Then a different staff person brings the student down to get more medication, not knowing the student isn't due yet. Nor do I know. Any suggestions?
Yeah, it's that's an ongoing problem, and one of the I think you have to start teaching the students. I don't know how old the students are, but engaging the students in telling everything they've taken, keeping a medication diary for themselves, especially if they're taking chronic medications. That's really important. I don't have an answer. You're not going to get full knowledge of what the student has taken. You're also not going to find out which students have some OTC meds stuck away in their pocket or lunchbox that they're taking. But I think if you can have a policy where students are allowed to self-administer if they provide documentation or somehow have an easy notification process, that will improve the situation. It's a matter of working and hopefully there's a nurse in the school every day that they can report this to. If there's not, that's again another problem. So it's certainly an issue, and I'm pretty sure most schools have that problem. certainly hospitals have that same problem where patients take medication from home that they bring in with them and don't tell anybody, and that does happen on a regular basis. You just have to try to work with the patients, the students, and help them understand the importance of sharing that information.
Krista is saying another issue is trying to care for recess injuries and give meds at the same time. So that's another issue.
Yeah, well, that's a time management issue and a resource issue. And again, document, the impact of what you have to do. That's a productivity study. What can you do? Tying the two together, though, it's been shown in some studies that when you have, if you look at asthma and diabetes, if you have low blood sugar and low oxygen levels, you're more accident prone on the playground. And so, you can basically, hopefully with a good, solid medication program in the school, medication monitoring program, you can reduce classroom, or playroom injuries or school classroom accidents.
Phil, I would like to add just one comment about the first question. I think one issue here too is sometimes it's not just about educating the parents. It's about working with your administrators. I know lots of stories of school nurses who just aren't getting that good sort of rigid support from principals and assistant principals, so that, if there's a policy about bringing medications, that comes not just from the school nurse, but is a school-wide policy and is well understood.
Yeah.
Sorry. Let me know when you guys are done.
We're done.
Sorry.
Next question. Next question.
Next one. You guys are getting a bunch coming in here, and I know it's 4 o'clock. So I think that we can continue to answer questions. We still have quite a few people on the line here. We're going to still go through the questions here, and we'll pick a winner.
Yeah, I'm fine. I can stay on. I don't have anything else at this point. I can stay on for a while.
Okay.
Me neither.
So Nancy says that she would like you to address drug diversion in more detail, which might be a whole other webinar, maybe. I don't know.
Well, it really is. But controlled substances or any drugs that might be diverted, and it isn't always only just controlled substances that are diverted. But drugs should be kept under lock and key. If it's a student's own prescription, it's kept locked. And what healthcare systems do, and I think a lot of schools do, is they actually have a count. The drugs are kept. There's an inventory, and so if the student brings in 20 tablets, each time one's administered, it's documented. At some point in time, hopefully on a daily basis, but if not, somewhat regular basis, there's an inventory and see if there's any diversion. See if the counts, if the number of drugs that should be in the vial are still in the vial. That's about, there's more sophisticated systems in hospitals that basically have automated computer-generated dispensing methods for controlled substances. They dispense the drug one at a time, and they document the student's name and all of that. I don't think schools have that sophisticated technology, so it's pretty much keep the drugs in a locked environment and keep an accurate record and have at least 2 sets of eyes looking on at that record to make sure that the proper number of drugs are dispensed and they're signed off for. That's what we do in hospitals. When pharmacy takes narcotics to the nursing unit, 2 pharmacy people sign off that it's delivered, and 2 nurses receive it. And then at each shift change there's a count, and 2 nurses verify that there should be 13 drugs in this bin or this vial, and they verify it.
Okay. Donna says, I'm a school nurse available for training. I train the teachers about auto-injector epinephrine, proper administration of rescue inhalers with or without aero chambers, yet I feel teachers are very cavalier about medication administration, especially for field trips. Health Services has instituted more rigorous signing out for medications, which emphasizes the importance of medication. But what else? I would also like to see peer evaluation of medication errors to use those errors as teaching learning tools.
Yeah, I think if first of all, I think the senior administrator of the hospital, the principal or superintendent or whoever it is, really has to support and get on board and say school health is really important. If students don't take their medication properly, they're not going to perform as students optimally. They're not going to perform in the playground optimally. That's important. Medication errors are a problem in our school, and teachers have to understand that that's important. And part of the reason could be that the teacher, again, this is something personal that I went through with my son when he needed to use his asthma inhaler and had to go to the school health service. One of his classes, there was no way he could actually make it to the school health area and back to class on time. He entered the room late, and the teacher chastised him. So the teachers have to understand that they have to support school health services. It's in the best interest of the student. The other thing I think that I'd like to see emphasized is that schools exist to teach students how to be successful in life, and part of that should be proper use of medication and proper management of their disease. And if the teacher starts seeing the school nurse as a teacher, teaching the student life skills, I think that might also help. But it has to really start at the top. The superintendent really has to support and the school health, anybody involved with school health and those processes.
I agree. It's, administrative support is essential.
So Patricia is saying, I have a few behavioral health providers that want to prescribe PRN psychotropic meds. I am not a pharmacist, by the way, such as clonidine for behaviors. Since I am not in the classroom to assess over time and all events leading to the behaviors, I refuse to allow these meds. What are your thoughts?
I think I would too. Psychotropic drugs they're not PRN drugs. They need time to develop. I also have to tell you, I'm an oncology pharmacist, so that's not my primary area of interest. But I do know the psychotropic drugs have to be over time develop, build up to a blood level for the drugs to be effective and to work properly. You just can't give them episodically as needed. I'm not sure the way to handle that. I would hope that the school board would have some kind of a medical advisor, physician that they have retained, and if so, I would take this issue to them and discuss it with them. Or at least I would have the physician write some kind of a policy on this. I'm uncomfortable with it as well, but if the student needs help and needs control, somehow they need to get the meds, but they need to get them in an appropriate manner. So this is a little bit out of my clinical area of expertise. I would hope that again, somebody on the school, some physician as an advisor to the school board would be able to help with that situation.
Dana would like to ask, is it considered a nurse error or a student noncompliance if they forget to come get their medication from the secretary when you are in another building at the high school level? So it sounds like she works a couple buildings.
Yeah, and that's an issue because the average nurse covers 2.6 schools, so they're not, at some given time that the nurse is not. In most schools, not most, many schools, there's going to be a time when the nurse isn't available. It doesn't really matter whose fault it is. That's where you get into this non-punitive, non-blaming culture. The fact is, the process is not conducive to the student being reminded and actually going to, that's where a teacher could help. You know, if the teacher knows the student's supposed to go get their medication, they can maybe remind them. You know, that's a process issue that needs to be addressed, and ideally if you need, you know, if you can get more help in the school health department, whether it's a nurse or an aide or somebody, so there's somebody constantly there, that would be helpful. You can have reminders, maybe electronically, maybe a phone app, or maybe some electronic reminder that the student can put in. You know, they can put into their daily planner, take your medication on this day. There's all sorts of ways to trigger and remind them. You just have to figure out what works best in your system, and maybe get what works best for the student. Ask them, you know, if they know the importance of taking the medication and how they would like to be reminded. Can they put it into some kind of a planner? Does somebody have to remind them? So a lot of different approaches to that. I don't know whose fault. You can't say whose fault it is. It's a system fault.
But I think you could say that it is an error.
It is an error. Yes, absolutely. Yeah. And it can be reported. And if you report it, you might find a trend. You might find that it's not one student. You might find that it's 50 students. And then you can do, and that might justify additional resources. And it might be electronic resources, it might be human resources, whatever it takes to fix the problem.
Jacqueline wants to know if you have any tips on adequately training staff on how to administer emergency medications, asthma pumps, EpiPens, for field trips or other times the nurse is not present.
Yeah, and that's a real concern. Pumps, obviously, each pump's different, and somebody has to do one-on-one training with that specific pump. EpiPens are pretty much on the box. They show you how, and I think if you talk to, you're still going to have to talk to those people, whether it's the bus driver or the teacher or even a parent chaperone or whoever is responsible. You know, show them on the medication package, or there's even one EpiPen that has some verbal guide coaching with it. Show them how to access that and how to use it. They're really very simple to use, but you need to show the people once how to do it, and in the process show them where to look on the package for prompts and cues, because you show them and then they probably may not need to do that for a couple of years, and they may have forgotten how, but at least they'll remember, oh yeah, there's something on the inside of the package that shows me exactly what to do. But if it's a pump, you know, that's going to require, you know, again, each one's unique, and so if they have a student on their trip with a pump, you might need to give them a little refresher course, or you know, create some guidelines. You might create a little cheat sheet or something like that, quick guidance exactly what to do if the pump alarms, how to change this. Well, they wouldn't be changing the setting, but what do you do if the pump alarms is probably the biggest issue.
I have about 6 questions left, just so you guys know. And I still have quite a few people listening, so I'm just going to keep going. Some of the many issues I'm having is parents not returning forms, their child's medical condition, and providing the medications at school. Asthma is the worst, and that's Carlene.
That's an ongoing problem. It's probably always going to be a problem, and it's just, you know, persistence. You know, individual calls to the parents. There's a lot of ways to communicate now too. Electronically, maybe the forms could be signed and returned, you know, electronically through email or through faxing, something like that. Maybe a note from the principal. Sometimes, you know, using a little higher authority would be important, or maybe the teacher could help with it. But it's getting the form signed has been an age-old problem, and getting parental consent to administer drugs has been a problem in some schools as well.
And it's, again, one of those things where you shouldn't be alone in trying to enforce those kinds of procedures. I think it's not just a parent issue, but educating your administrators about this.
Who is next here? So Eileen wants to know, what are the legal implications of the school nurse giving the teacher the student medications to take on a class trip? Is this dispensing?
No, it's really because you have the parents are actually providing the drugs usually in the form of a student prescription. So basically, the nurse is acting as an agent of the parent to administer the drugs. Anybody can administer the drugs from a prescription vial with the directions on it. That's from a legal standpoint. In a school environment, it's best if the nurse does it because it's a controlled healthcare process. You're monitoring the student and all of that. But anybody legally, can help assist the student take a drug that has been prescribed and is properly labeled. That's not an issue. I think the importance would be to, again, go talk to that teacher or whoever it is, teacher or coach or band instructor or somebody, and tell them about this drug, especially if it's something unique that they need to know. And so just remind them the importance of it, so they take it, so they understand the importance of it. But legally, there's, if it's a filled prescription for the student, anyone can help the student, assist the student in taking it.
Okay, and I'm going to do a quick drawing since we are over 15 minutes over time, and people have to be present to win. So I am going to do the quick drawing here since we still have quite a few attendees on, but I don't want to. I want to respect your time. So let's do a quick drawing here in the middle, and then we'll finish these questions. Good. And the winner is Robin Scott. So Robin Scott, you win.
Congratulations, Robin.
Yeah, congratulations.
Robin, I have your email and your contact information, and you will be getting an email from me to coordinate the winning prize. Okay? Congratulations. So, so now everybody's probably going to drop off, but we'll see. So Jennifer wants to know, medication counts on controlled substances are to be performed every 2 weeks in our school system. What documentation practices do you recommend for this practice?
I would have an inventory for each drug, and it's just a grid. You sign off, the date or the starting inventory, and then each time the drug is dispensed, you document the time and the day and the time and the dose, and keep that ongoing. You have a separate, it could be a card, it could be a sheet of paper, it could be an electronic record, and then every 2 weeks it's going to be. It sounds like it's going to be a double count. That's probably that's a good system. Actually the book that I wrote has some model forms in it, and that would be one of the forms that's in there. So everyone will be getting a copy of that.
And Teresa is saying, you've addressed K through 12, but preschool programs have many of the same issues as schools, but often compounded. Our students cannot administer their own medications or communicate to the extent that older children can. In addition, we typically don't have the number of nurses that K through 12 schools do. We can be very large, like for instance, we are a Head Start program serving over 1,600 children 0 to 5.
Huge resource problem. Again, document the value of what you do and the value of what you do, and what you can't do because you don't have the resources to do it.
Right, and I guess I'm I'm sure that this isn't a unique problem, and I guess I'm wondering what Head Start policies are on this issue. I mean, they are operating under the same laws as far as serving children with disabilities that the schools are, and I guess I think that guidance from your Head Start administrators and trying to get some advocacy going amongst other providers to address this issue, that sounds terrible.
The next one is in regards, actually we have Catherine chimed in here. She just wants to point out in New Hampshire parents cannot delegate, and she wanted to make sure that everyone knew that from New Hampshire. That was her comment. In regards to training staff question, the New Mexico School Nurse Association borrowed a procedure that was produced by NASN, really good presentation for students and staff. So that's another, had some comments here, some helpful comments. Kendra says, my biggest problem is getting parents to pick up medication at the end of the year, especially EpiPens. Any advice on how to get the medication back to parents without disposing the EpiPens or inhalers and or other important meds?
Well, if the student's responsible, you can send it home with the student. The only other thing you really can do is to tell them, we'll hold it a week before the school ends, the school session ends. Tell them that you have to pick up the medication and they'll be discarded if you don't. I guess the other way you could do it would be if you want to mail it to them through registered mail. You could probably do that. But probably the best way is if the student's responsible, send it home with the student, or just again send them a notification that according to school policy, we cannot retain the inventory of these drugs after the end of the school year. So you have until such and such a date to pick them up, beyond which we will dispose of them. But you need to give them at least a week's notice.
Okay. And it looks like we have some more suggestions coming in. Oh, here, Jennifer says, many faculty staff members request that I administer their injectable medications to them. What is your position on this practice and what liabilities exist? As a nurse, I think you're certainly trained to do that. You're not a licensed healthcare facility like a hospital is, so you're not covered by their malpractice coverage. You're operating as an independent professional at that point in time, and so if there is an error, you could be liable. The likelihood of that happening is very minimal. So I would look at the situation. If you feel comfortable administering the drug, you certainly are trained to do it, or are trained to teach them how to do it themselves. Sure.
I'm just these are complex questions, and there's a lot of different ways of addressing each of them, and each situation is a little bit different. I'm just giving you thoughts off the top of my head.
Right. I think that might be a topic for another presentation, because my guess is that the liability policies in the school would affect that, and those probably vary.
Yeah, there's a lot of questions and suggestions kind of coming in regarding that. So, Patricia's saying, if you provide care for a staff person, shouldn't you have a method to document it? Amy's saying, returning medication, in regard to the returning medications issue, we attach a letter to the meds in school form. We call in, or we send in May. They call in May and send a letter home as well, and they still have trouble getting it all picked up. So they're definitely, and then another issue that somebody reported here said that it's an error if we don't give a med, but if a parent doesn't provide it, what can we do? So it's such a hot topic, and there's so many.
Well, if the parent doesn't provide it, you can also call the physician, if that's possible, and let them know that I understand that your patient is supposed to be getting the meds, but we don't have it yet. Maybe you can call the parent. I mean, obviously that's assuming you've persistently contacted the parent by sending notes home, by calling them, by sending emails, by notifying them in a variety of different ways. What do you do with an irresponsible parent? I don't know. There's no good answer for that except be as resourceful as you can. You also might again have the school administrator send a letter to the parent saying that your child requires medication. I don't think you're going to not say the student can't attend school unless they bring it in, but you certainly can put pressure on them in other ways. I know that irresponsible parents are a huge issue. I can tell you that nationally, 25% of all prescriptions that are written are never filled. That's been going on for over 20 years. And of the ones that are filled, 50% are not taken as directed. And this is by adults treating themselves. So when you start getting a parent who is either busy or irresponsible, both of those things happen, and get them involved, and all sorts of things can happen that are not necessarily good. So there's no one answer that fits every situation. You just have to be as persistent and forceful as you possibly can to make these things happen on behalf of the child. And then document when it doesn't happen. Somehow document in the student's record. Mother did not provide, or parent, guardian did not provide the medication.
So I know that I'm getting some messages that people do have to leave. But we still a lot of people on the line. But we still have a lot of people on the line. But I am getting messages that people have to go. You will receive your certificate of attendance, so you can definitely jump off if you have to go. And don't worry, I will still send you your certificate. And just one more question. It's from Sherry, and she wants to know, how do you suggest schools dispose of expired medications or leftover medications? Can the nurse transport the expired or remaining meds to a medication drop-off location?
Well, yeah, and actually there's a section in my book on that too, and it's very unclear as to exactly what can and should happen. It varies by state, and it gets involved with the Department of Environmental Protection and all of that. Ideally, what hospitals and nursing homes have methods of disposing. We have actually companies that dispose of medication, and I would suggest call the local hospital and say, do you mind? Because I never minded. I'm in Tampa, Florida, and I never minded when schools would drop off a few medication. I just throw them in with all the other medication residuals that we had disposed of. Those are put into a sealed container, and they're ultimately incinerated. Nursing homes sometimes have that as well. The other thing you can, obviously, I'm not supposed to say this, but how would you dispose of it if it was in your own home? There's a lot of controversy over whether you can flush the drug down the toilet or not. And I'll just give you my my very biased opinion on that. People say that contributes to the drug ending up in our environment. But when you take a drug, for the most part, the drugs are excreted. A major part of that drug is excreted unchanged in the urine anyway. So, the drugs ultimately, whether you put it in the toilet directly or filter it through the human body, is going to end up in the same place. So, I mean, but legally, that's not something that you can do. But if it's a couple of pills, that's certainly what I would do. There's other guidance that's out there of how to put the drug, for example, in a used empty milk carton and detoxify it with something like plaster or Paris or something like that, paper mache or something like that would make it difficult to retain, and then it gets thrown in the garbage. Well, that ultimately, that's what one source would recommend, but there's others. People people who disagree with that as well. So the ideal thing is if you have a significant amount, I would contact your local hospital or nursing home and see if you can include it in their medical waste. I'm sure it's not going to be more than at every semester or quarter that you would be doing this, and I can't imagine there would be a tremendous amount. Even if you have to cover the cost of it, it wouldn't be probably that much to purchase one of the containers that the hospital or nursing home would use. Those are just some suggestions, but that is covered in the manual that I wrote that you're going to be getting. It talks about what the Environmental Protection Agency recommends.
Okay. All right. Well, I think that concludes our session for today. I just want to thank everybody for hanging in there with us, and this sounds like a really, meaningful topic to school nurses. So,
well, I thank you too.
Yeah,
these are really difficult issues, and there are no good answers, and everybody's struggling with them. So, each situation is different, and be resourceful and share when you find something that works, share it. And that's what's really important as well.
Right. I think it's always a little awkward. I think the exchanges like this are so powerful, and I think we'll find ways to respond to some of your questions and maybe plan some other sessions as well. So thanks.
Okay. Well, have a great night, everyone, and congratulations again to Robin. And everybody who attended will receive a certificate of attendance, a link to the recording that will include Barbara as part of the presentation, a link to Barbara's PowerPoint just as a PDF file, and any other resources that Barb, Phil, and I kind of brainstorm after the call here that we think will help based off of your questions. But it sounds like a lot of it will be covered by Phil's digital book that everyone will receive a free copy for. So thanks again, and have a great night.